A very good afternoon. Today we're going to discuss about anatomy of temporomandibular joint and TMJ ankylosis. The topics that I'm going to cover today are the embryology of temporomandibular joint, anatomy, the characteristics of temporomandibular joint, and in detail about temporomandibular joint ankylosis. That is, its classification, clinical features, radiographical features, approaches to TMJ, surgical approach, its complication associated with the surgery, and conclusion. Starts with the embryology of TMJ. It starts developing between 7 to 12th week of gestation from two separate blastomes, that is the temporal and condylar blastomes. Superior to the condylar blastome, a band of mesenchymal cells differentiate and form the articular disc. Now these two separate blastomes, that is temporal and condylar, they form osteoblast and eventually membranous bone is formed. But the center of these condyle, cartilage developed, termed as secondary cartilage. This causes subchondral bone formation. Now this procedure is termed as endochondral ossification. Now enlargement of the condyle in the adult is because of this endochondral ossification, which occur because of adaptation to overload. Now as we know, there is an articulating disc between the head of the glenoid fossa and the head of the mandible. The developing disc is highly cellular and vascular. Anteriorly it is attached to the lateral pterygoid muscle and posteriorly it has ligamental attachment, that is discolamellar ligament or Pinto's ligament. In the natal life, this Pinto's ligament is attached to the malleus of the middle ear, whereas in postnatal life, this Pinto's ligament is attached to squamotympanic fissure. Let's move on to the surgical anatomy of temporomandibular joint. First, we begin with the bony component. It has two articulating surfaces. One is the cranial component, the other is the mandibular component. The cranial component is the glenoid fossa. The glenoid fossa is formed by the squamous part of the temporal bone. It is limited anteriorly by the articular eminence and posteriorly by the postglenoid tubercle. It is concavo-convex in shape and it is covered by an avascular fibrocartilaginous tissue. Then the condylar head is another component of temporomandibular joint is the condylar head and neck. Now this head and neck is also covered by the fibrous avascular cartilaginous tissue. Now this head and the neck of the condyle along with the glenoid fossa is reinforced by the mandibular ligament or called as the temporomandibular joint capsule. Now this is a fibrous capsule. It starts from the margins of the glenoid fossa and adhere to the periosteum at the neck of the condyle. It restricts the movement of the condyle. The inner aspect has synovial lining which secrete the synovial fluid. Now this lateral capsule is further reinforced by the lateral ligament or temporomandibular joint ligament, which start from the articular eminence, move downwards and backwards and attaches to the posterior part of the neck of the mandible. Now this ligament restricts the movement of the mandible in anterior and posterior direction, that is, it prevents unnecessary mandibular movement and dislocation. Hence it is termed as the check ligament. The other accessory ligament are spinomandibular ligament and stylomandibular ligament. Spinomandibular ligament arises from the spine of the sphenoid and it is attached to the lingula. The surgical importance is that is internal maxillary artery and auriculotemporal nerve is between the mandible and spinomandibular ligament. The next ligament is stylomandibular ligament, which is attached to the styloid process to the angle of the mandible. It is nothing but thickening of the deep cervical fascia. Then we move on to the articular disc. Now the entire TMJ joint capsule is divided into two compartments by an articular disc. Now this disc divides the compartment into superior and the inferior compartment. Superior compartment is wider, whereas the inferior compartment is thin. The volume of superior compartment is around 1.2 ml, where that of the inferior compartment is 0.8 ml. Now the disc is concavo-convex in cross-section to stimulate the articular surface. Now it has three parts. It has the anterior lamella, the middle lamella and the posterior lamella. The anterior lamella thickness is around 2 mm, whereas the middle lamina is very thin, it is around 1 mm, and the posterior lamina is very thick, that is 3 mm. The posterior lamina is highly vascularized and innervated by the auriculotemporal nerve. Then we move on to the blood supply of temporomandibular joint. The lateral part of the temporomandibular joint is supplied by the superficial temporal nerve, which is a branch of external carotid artery, whereas the deep and the medial surface is supplied by the internal carotid artery and its branches, that is the deep auricular, posterior auricular and masseteric branches. The nerve supply is basically from the mandible, that is auricular temporal nerve, masseteric nerve and posterior deep temporal nerve. Let's move on to the movement of the temporomandibular joint. Temporomandibular joint is called as guillemot-diarthrodial joint. That is, both the joint has to move simultaneously and each joint has two separate compartments wherein two different movements take place. Okay, as we know that the articular disc is attached to the lateral capsule, medially and laterally. It basically restricts the movement with the help of collateral ligament, which restricts the movement in the mediolateral direction. So the articular disc can rotate in anterior-posterior direction but not in the mediolateral direction, because of which the condyle can rotate around its axis within the encompass of the disc. And condyle along with the disc can have a gliding motion along the glenoid fossa. So you have two joint space with two different type of movements. So when you open the mouth, the condyle move over the articular eminence and glide over the articular eminence, and your articular disc move behind, that is posterior to the condyle. When you close the mouth, the movement is reverse. The lateral pterygoid muscle relaxes and the condylar head is moved back and the articular disc sits on top of the condylar head. Now these movements are also facilitated by the masticatory muscle, wherein the opening is basically caused by the depressor group of muscle, wherein the digastric muscle play an important role. The geniohyoid and sternohyoid muscle play an important role. In this, the triggering factor is the lateral pterygoid muscle. It contracts and depresses the mandible and helps to open up the mouth. Wherein the mouth is closed with the help of masseter, temporalis muscle and the medial pterygoid. When you're doing a protrusion of your mandible, this is because of the simultaneous contraction of the both lateral and medial pterygoid muscle. When you're doing retraction of the mandible, it is mainly because of the posterior fiber of the temporalis muscle. Let's move on to the characteristics of temporomandibular joint. A number of names has been given to this joint: complex, multiaxial, synovial, bicondylar and guillemot-diarthrodial joint. Now this is because of its wonderful characteristics. To begin with, the articular surface. Like any other articular surface in the body, which is mostly lined by hyaline cartilage, the articular surface of temporomandibular joint is lined by avascular fibrocartilage. Then, as I mentioned earlier, the movement of both the joint is coupled together. This is because both the joint is joined together with the mandibular body. Then, the mandible is stabilized at 3 points, that is the 2 joint and 1 the dentition. It has a rigid endpoint closure because of presence of dentition. There is a close connection between the cervical spine TMJ and the occlusion. So any discrepancy in any of these things can cause disorder of the other. It also acts as a regional growth center for the development of the ramus of the mandible, middle third of the face and the lower face, because of the adaptive changes that take place in the functional matrix of the soft tissue and the masticatory apparatus. If there is some hindrance in these functional matrix of the soft tissue, the bony growth is hampered, which is eventually seen as change in the facial, or you can say facial asymmetry in the lower third of the face. Let's move on to TMJ ankylosis. As the word suggests, ankylosis in Greek means stiff joint. So there is less mobility or no mobility at the TMJ joint. Now they can be classified as false ankylosis or true ankylosis, extra-articular ankylosis or intra-articular ankylosis. Depending upon the union, it could be fibrous or bony. Either one side is affected, so unilateral, bilateral, or partial or complete ankylosis. Let's move on to the etiology of ankylosis. It can arise because of trauma. Trauma can be during birth, that is during forceps delivery, wherein forceps is applied at the condylar region, can cause injury to the TMJ and result in ankylosis. It could be trauma after birth, that is because of any kind of road traffic accident that has caused injury to the temporomandibular region, can cause hematoma formation and ankylosis. It can be because of infections, chronic infections like osteomyelitis, sarcoidosis can cause TMJ ankylosis. Any inflammatory process like rheumatoid arthritis of the TMJ joint can also cause an ankylosis. Systemic disorders can also result in TMJ ankylosis. Let's take a look at the pathogenesis that is involved in TMJ ankylosis. Whenever there is injury or trauma, there is pooling of blood in the affected site. There is collection of blood which results in formation of hemarthrosis. Now this hemarthrosis eventually form granulation tissue which form dense fibrous connective tissue. After this, which undergo organization and form thick bone resulting in ankylosis. Let's move on to the clinical features. It depends upon three things: severity of ankylosis, the time of onset of ankylosis, and duration. Early joint involvement: if there is trauma before the age of 5 years, there is severe facial deformity and there is severe loss of function. If there is deformity after the 5 years of age, the facial deformity is not much, but the functional loss is too much. Take a look at the clinical features of TMJ ankylosis. As you can see in this photograph, in case of a unilateral ankylosis, there will be facial asymmetry. The chin is deviated towards the ankylotic side. There is roundness of the face towards the ankylotic side. There is flattening or elongation of face on the unaffected side where the condyle is growing normally. The chin is protruded and retracted. The patient will have a crossbite. There will be class 2 malocclusion, and there will be presence of an antegonial notch on the affected side. In case of a bilateral ankylosis, the facial symmetry is maintained because the mandible is retruded and retrognathic symmetrically. You will have a typical bird-shaped deformity. The bone, that is the mandibular bone, chin to neck angle is 0 or it is very, very obtuse, as you can see in this photograph. There is projection of the anterior teeth, there is crossbite, narrowing of the arch of the maxilla, and there is scissor bite also seen. Then move on to the radiographic feature of the ankylotic mass. As you can see, this is a normal radiograph where you can appreciate the temporomandibular joint and the joint cavity, whereas in case of an ankylosis, you will not be able to appreciate the neck of the condyle or the sigmoid notch. Rather than you will see a continuous block of radio opacity. There is also a 3D reconstruction image which will show you how a live 3-dimensional ankylotic mass is seen. Now Shawnee in 1986 has graded TMJ ankylosis depending upon the severity of the bone involvement into 4 types. Type 1 ankylosis, in which the condylar head is present, it is not much deformed and there is fibrous union. Type 2, there is involvement of the condylar head along with the glenoid fossa, but the sigmoid notch is not affected. Type 3, there is bony bridging between the zygomatic arch and the glenoid fossa, and there is elongation of coronoid process. And type 4, there is a normal anatomy of TMJ is completely hindered. You will see just a bony chunk. You will not be able to see either the sigmoid notch nor the coronoid process. Just a bony block is seen. Let's move on to the treatment or management of TMJ ankylosis. 4 things you need to keep in mind. First is release the ankylosis, correct the function of the joint, restore the vertical height of the mandible, and prevent recurrence. Now, before we go on to the surgical procedure, there are many approaches to see or treat the temporomandibular joint. Submandibular approach, post-ramal approach, preauricular approach, and bicoronal approach, of which the preauricular approach and its various modifications are most commonly used in case of unilateral ankylosis, whereas in case of bilateral ankylosis, we offer a bicoronal approach or an Opweiser's approach. Now, before we go on to the surgical approaches, we need to take a look at the surgical anatomy of facial nerve. Facial nerve leaves the skull from stylomastoid foramen. Okay, as soon as it comes out of the skull, it gives 2 branches. Okay, it gives temporofacial and cervicofacial branches. Now, this temporofacial and cervicofacial branches, they arise at least 1.5 to 2.5 centimeter below the greatest concavity of the external auditory canal. Okay, so you need to keep this thing in mind when you are doing your incision to preserve the main trunk of the facial nerve. We are also aware that these facial nerves terminate into 5 main branches. That is the temporal, zygomatic, buccal, mandible and cervical, as you can see in this photograph, of which we are more concerned with the temporal branch. It is said that the temporal branch is around 1.5 to 2 centimeter away from the anterior margin of the external auditory canal. Sometimes it is as close to as 0.8 centimeter and as far to as 3.5 centimeter. So when you're giving a preauricular incision, you should be, and when you're cutting through the zygomatic arch and periosteum, you need to be less than 0.8 centimeter. If you are more than 0.8 centimeter, there are chances you might injure the temporal branch of the facial nerve. Let's move on to the preauricular incision. As you can see in this photograph, it starts from the helix of the ear and go along the crease between the face and the ear till the base of the earlobe. Let's take a look for the modification. The first is the Blair's modification. It is nothing but an inverted hockey stick incision. You'll take a 2-finger breadth of curved C-shape incision till the helix, then move anteriorly to the ear till the lobe. The next is thoma angulated incision, wherein along with the preauricular incision, you give a releasing incision anteriorly at an angle of 45 degrees. Now these variations are basically to increase the access to the ankylotic mass. So if the severity increase, your incision will vary. The third one is Alkyd-Bramley incision, most commonly used when you are planning to remove the ankylotic mass and use a temporalis fascia flap. In this case, this year more than 2-finger breadth incision is extended into the parietal region of the skull along with a preauricular incision. Now once you have done the incision, you move on to the surgical procedure, that is removal of the ankylotic mass. You could either do a condylectomy, that is remove the head of the condyle if it is just fibrous union. You could do a gap arthroplasty. Gap arthroplasty is nothing but creating a gap between the two articular surface. But what happened with gap arthroplasty is you're removing the bone. There will be blood, again there will be hematoma formation, the chances of re-ankylosis increase. So to avoid this, we started using of interpositional gap arthroplasty. Okay, now interpositional is you're putting something inside the gap so that the reunion doesn't take place. Now this interposition gap arthroplasty can also be done with the use of cartilage or costochondral graft. Or the other treatment modality could be distraction osteogenesis. We'll take a look at each of these step by step. To begin with the gap arthroplasty, in this figure you can see a thoma incision is given, that is preauricular with and a 45-degree angulation. Okay, complete exposure of the ankylotic mass is done. Once you expose the ankylotic mass, you first make the inferior cut. After making the inferior cut, you make the superior cut in such a way that the gap between the two articular surface is 1.5 to 2 centimeter. You want the gap to be more to prevent any kind of re-ankylosis. Also make sure that you remove any kind of bone debris which are present on the medial aspect. Sometimes a mesial fragment of bone can also result in re-ankylosis. At the same time, you have to keep an instrument on the medial aspect to prevent the pterygoid plexus and the internal maxillary artery. If you don't protect it, the bleeding can occur. Once you have done this, you have created the joint space. This is what you see, as you can see in this photograph, preoperatively, minimal mouth opening. You can see an ankylotic mass. The sigmoid notch is almost disappeared. There is elongation of the coronoid process is also seen. Post-surgery, that is after gap arthroplasty, the mouth opening is satisfactory. On the OPG, you could appreciate the gap between the two articular surface. Okay. Now this slide shows the procedure of temporalis myofascial interposition. In this case, we have used an Alkyd-Bramley approach for this. More than 3-4 centimeter curve incision followed by preauricular incision. Now this is basically done to expose the temporalis muscle. Okay, after you remove the ankylotic mass, you take a temporomyofascial flap. Now either you could take full muscle mass or you can take either the anterior, middle or posterior section depending upon the age of the patient and the gap you have created. So you will remove this myofascial mass and you will put between the gap. Now there are two schools of thought. Either you could go over the zygomatic arch or you could go below the zygomatic arch and suture this flap on the lateral area. Either of the way is alright. Okay, what are the other materials that could be used as an interposition material? Like autogenous material like cartilage, like costochondral cartilage, auricular cartilage can be used. Temporalis fascia, fascia lata and dermis can be used. Heterogeneous material like chromatose submucosa of pig bladder, lipolyzed bovine cartilage can be used. Alloplastic materials like metallic and non-metallic materials can be used. Now, the most popular protocol for the TMJ ankylosis is the Caban's protocol given in 1990. Okay, Caban state that the earlier you treat these conditions, the better is the patient. The less facial deformity, the less functional deformity. Okay, so early treatment is important. Aggressive recession. Remove the entire ankylotic mass along with the mesial bony projection also. Okay, then ipsilateral coronoidectomy and temporalis myotomy. Now, after doing an ipsilateral coronoidectomy, if you see the mouth opening is 35 mm on table, you do not do a contralateral coronoidectomy. But after you have removed the coronoid of one side, but the mouth opening is less than 35, then you have to remove the coronoid of the other side. Why I am removing the coronoid is, it will increase the mouth opening. Because of the elongated coronoid, it gets impinged between the zygomatic arch and the infratemporal fossa, and your opening is restricted. So basically, we want a better mouth opening. That's the reason why we're removing the coronoid process. So once you have removed the coronoid process, you have raised a myofascial temporal flap. You line the glenoid fossa with this temporalis flap. Either you could line this or you could reconstruct the gap that you have created with costochondral graft followed by closure. Early mobilization is a key of success in case of TMJ ankylosis. You might think patient has undergone a surgery, how to start a mobilization on the next day, but you have to start jaw exercise on the next day of surgery. Because if you delay, the bone will consolidate and reunion will start. Along with that, long-term follow-up is a must. In 2009, Caban has also modified this protocol by introducing distraction osteogenesis into it. What exactly is distraction osteogenesis? It is nothing but formation of bone as well as soft tissue. You incrementally increase the osteotomy segment size so that there is bone as well as soft tissue is formed. So by doing distraction osteogenesis, you maintain the height of the ramus and you maintain the facial symmetry. This is a radiograph where you can see the ankylotic mass preoperatively after the osteotomy and placement of three-dimensional distractor. In case of three-dimensional distractor, it will move the mandible in downward, forward and lateral directions. Let's move on to the complication of TMJ ankylosis. Now, complication can arise during anesthesia. Since the mouth opening is minimal, you have to do blind awake intubation, for which patient's compliance is a must. Most of the time, the patient will not listen to you. It can swallow, can aspirate. So you might have to do an immediate tracheostomy or a cricothyroidectomy at that time. Then post-operatively, there are chances of tongue fall that can take place. Then during surgery, when you're removing the ankylotic mass, there are chances you might enter into the middle cranial fossa, or you might injure the vascular supply like the plexus and internal artery, which will bleed. You need to pack it again, wait once the bleeding stops, then you start the surgery again. Now, during the post-operatively, there could be infection, there could be open bite and recurrence of TMJ ankylosis. With this, I would like to conclude by saying that maintenance of ramal height is a must, and maintenance of the mouth opening is utmost important in the surgery of TMJ ankylosis. Now, distraction osteogenesis is a new treatment modality available for the ankylosis, which is very feasible, which can increase the mouth opening as well as maintain the height of the ramus, and it is more comfortable for the patient. Thank you.